Buen día. Good day. I want you to meet Juan. Juan is a healthy 60-year-old farmer who lives in the city of Victoria, in the southern end of Chile. He one day wakes up feeling sick, with flu-like symptoms. He has fever, a runny nose, sore throat, headache, and lots of muscle ache. A few hours later, he decides he should go to the emergency service of the local hospital because he's feeling worse and has now developed shortness of breath. When he arrives to the emergency service, he's found to be febrile, tachycardic, tachypneic, and saturating 88% on room air. Although this could be a common respiratory viral infection or incipient community-acquired pneumonia, the doctor decides to hospitalize Juan, and besides the usual workup test, he also orders a rapid test for hantavirus. You see, hantavirus infection is endemic in southern Chile. Hantavirus is a nasty little virus that can make your lungs go from this to this in a matter of hours. Of those who present to the health services and are diagnosed with hantavirus infection, only a small proportion will have a mild form of the disease. The majority will develop either severe respiratory failure or a cardiopulmonary syndrome with profound shock and multiple organ dysfunction, with up to 90 to 100% mortality. The thing is, though, patients with Hanta will actually get better on their own after a few days. However, keeping them alive through that period of time is many times impossible because of how sick they become, unless you connect them to ECMO. Providing ECMO in severe forms of hantavirus infection, together with good ICU care, has shown to improve outcomes from close to 0% survival to 60% survival. Such is the case that the Chilean Health Ministry and the Society of Intensive Care Medicine have developed guidelines recommending that any patient with confirmed hantavirus infection must be urgently transferred to an ECMO-capable center. So let us go back to Juan. In just a few hours, he has gone from oxygen to nasal prongs in the ward to mechanical ventilation on prone position with 100% FiO2 and high-dose vasopressors in the ICU. He is big sick, and his labs have come back, and he is positive for hantavirus infection. He must be transferred out to the closest ECMO center, but is now too sick to be moved as he is. He will have to be transferred on ECMO. So an ECMO-capable retrieval team from Santiago is activated. Now, the first time I heard about the tyranny of distance was in Australia, and I remember thinking, how lucky am I to live in a place like Chile, where one can drive a car from the Andes Mountains all the way to the Pacific Ocean in just over 3 hours. But it turns out I was looking at it the wrong way. Literally, I was looking at it east to west. But if you rotate your head 90 degrees and look at it from north to south, we have a much bigger distance problem than most countries, including Australia. In addition, Chile is a Santiago-centric country. Half of the country's population lives in Santiago. Most tertiary referral hospitals are located in Santiago. Until recently, the only ECMO-capable centers were located in Santiago, and even today, the only center that provides ECMO transfer is also based in Santiago. Fortunately, Victoria is only 700 kilometers from Santiago, and the weather is on our side today. Frequently, rain, fog, and wind cause significant delays for aeromedical retrieval in southern Chile. So, after a couple of hours, the airplane lands in a nearby airstrip and the retrieval team reaches Juan and manages to successfully connect him to ECMO support. Once in ECMO, oxygenation quickly improves and vasopressor requirements decrease significantly. Juan is then packaged, put on an ambulance, transported to the airstrip, and loaded onto the plane. So the team is very happy. because everything is going extremely well so far, and they will soon be home. But then, several minutes go by, and they're all sitting inside the plane in complete darkness, and not much is happening. There's no energy, no lights, no pilot around. And when the perfusionist looks outside his window, he sees the pilot and an assistant running back and forth, removing batteries of nearby cars and lining them side by side next to the plane. It turns out it is now 3 a.m. Temperature is minus 10 degrees. The plane's battery has died, and because this is a small airstrip, there is no plane battery jump starter. So the pilot is desperately trying to MacGyver his way out of this one. At this point, the retrieval team leader decides it will be safer to call back the ground ambulance and start a 6-hour-long ride back to Santiago. They do make it back safely. Juan requires a lot of support for the next couple of days, but then starts to improve. ECMO is discontinued at day 6, and Juan is discharged home 2 weeks later in good condition. So as you have seen, rescue and retrieval medicine in Chile is commonly challenged by long distances, bad weather, suboptimal resources, and even aggressive endemic viruses. However, those are not the biggest challenges we have. Perhaps James Clear puts it better when he says that we do not rise to the level of our goals, but instead we tend to fall to the level of our systems. Building a robust, redundant, and integrated rescue and retrieval system is by far the biggest challenge we face in Chile, and fortunately, one that many motivated people and teams are currently working to overcome. Thank you very much.
Okay.